Hi, Dr. Bhargava here. This is the next video in the series Body Imaging Case Review. This is our first patient, and so here the teaching point is how to differentiate between haustra, which are physiologic and seen normally in the colon, from diverticuli, which are pathologic and seen predominantly in the distal colon. So haustra are physiologic and they are separated from each other or are at equidistant in the colon, and diverticuli are predominantly in the distal colon. They are small outpouchings that are randomly located and can rupture or get inflamed, causing diverticulitis and subsequent complications. So it's important to differentiate on imaging between haustra and diverticuli. Here is our next patient, and here what we're trying to do is differentiate between consolidation and atelectasis. So consolidation is when the airspace is filled with fluid or pus and there is no volume loss. So here on the CT scan, in the axial image, we find that there is a right upper lobe consolidation. It is seen superior to the fissure and there is no volume loss, also seen right here. So the fissure is here and the consolidation is right there. The next patient, the images below show bibasilar atelectasis, where there is collapse, and because of the collapse there is crowding of the airways and the vessels, and we see the volume loss. The lower lobes look smaller, especially here on this side. And so atelectasis is characterized by collapse, and consolidation is opacification, which does not show lung collapse. This is our next patient, and here on the bone windows on their CT of the abdomen and pelvis, we see a stone inside the urinary bladder. You can see the layers of calcification of this stone. Anytime there is stasis of urine, it is likely that the stone will develop, and urinary bladder stones are frequently seen when there is outlet obstruction, such as enlarged prostate or in females urethral stenosis. This is our next patient who presented with abdominal pain, fever, and chills. We performed a CT abdomen and pelvis. We found that the uterus is enlarged. We have a scar here. They had a recent C-section, and there is this fluid collection with foci of air and some peripheral enhancement in the abdominal wall at the site of the C-section scar. And so this is a developing abscess post C-section. Here's our next patient, same patient scanned at two different time points with multiphasic CT looking for a tumor in the liver. And so on the first scan, we find that the liver on the non-con image is hypodense, suggesting steatosis. We see this hyperdense mass that shows centripetal enhancement consistent with the hemangioma. And on the follow-up scan, the liver is smaller, the surface is nodular, but it's not steatotic. And so now this mass is hypodense compared to previously hyperdense, and it shows enhancement pattern consistent with the hemangioma. So as the liver disease worsens, these benign tumors become smaller in size, and their appearance, especially on non-con, is dependent on the appearance of background liver. So when the background liver was dark with steatosis, the lesion appeared hyperdense, and when the steatosis went away, the lesion on the non-con became hypodense. This is our next patient, and here the finding is in the pancreas, where we see this benign appearing fat. And this is a good example of a rare pathology of a pancreatic lipoma. Next patient. Frequently, when we read CT of the abdomen and pelvis, the lung bases are in the field of view and they may show some pathology. So here we find that the left ventricle is dilated, the left ventricular myocardium is thin, there are bilateral small pleural effusions, and in the lung windows we see these joining web-like lines consistent with interlobular septal thickening consistent with interstitial pulmonary edema. So putting all of these together, this patient has congestive cardiac failure. Here's another patient where there were findings in the lung basis on a CT of the abdomen and pelvis. In the lung windows, we find a nodule, and this is its appearance on the soft tissue windows. There is central punctate calcification, suggesting that this is a benign nodule. Here's our next patient. We performed a pelvic ultrasound to evaluate IUD, and here is the uterus that I'm outlining. Endometrium is right here, and towards the fundus we see this linear straight echogenicity, which is the IUD, and posteriorly there is shadowing because it's not letting any sound waves go past it. This is its appearance on the axial image. Here is the uterus, that's the endometrium, that's our IUD, and the shadowing below or posterior to it. This is a single small field of view T2 weighted image from MRI of the pelvis in a female, showing urinary bladder with some urine inside, vagina distended with gel, small volume free fluid, could be physiologic in this young female. There are tiny Nabothian cysts in the cervix. Here is the endometrium, and there are multiple nodular T2 hypointense foci throughout the myometrium, consistent with small fibroids. Here is another patient where we have performed multiphasic CT, non-con, arterial phase, portal venous, and delayed. We are evaluating this hypodensity in the left lobe of the liver. It shows centripetal contrast enhancement consistent with the hemangioma. Here is our next patient, another multiphasic CT of the liver where we find that there is a heterogeneous tumor, and this tumor shows heterogeneous arterial phase contrast enhancement, and there is washout seen right here, consistent with an HCC. And the interesting finding is that the tumor extends into the main portal vein, where we see the tumor showing arterial phase enhancement and also delayed washout. So it's a LRTIV, or tumor in vein classification. This is our next patient with an interesting incidental finding. CT of the abdomen and pelvis was performed without contrast, and we see this hernia on the left side. So this inguinal hernia has a fluid-filled structure with a thick wall, and on the sagittal we find that this is the urinary bladder that is herniated into the spermatic cord and into the scrotum. So urinary bladder herniation is rare, but is possible. This is our next patient where the finding is subtle, almost like an eye test. So look at the vein here. Compare the vessels on the left side to the right side. The right-sided vein is expanded and there's a filling defect, also seen right here, expanded vein with filling defects. So DVT that was detected on a CT abdomen and pelvis. This is a chest x-ray showing in a large patient. We see a lot of soft tissues, and we see this paracardiac density on both sides, and this is also seen on this scout image from their CT. And again, we see this very large patient, probably 500 to 600 pounds, and this is paracardiac fat pad that was seen on the chest x-ray. This next patient underwent a Dotatate PET-CT to look for a recurrent neuroendocrine tumor. We see physiologic distribution in the pituitary, salivary glands, liver, spleen, kidneys, adrenals, and excretion into the urinary bladder. And the interesting finding here is some minimal uptake in the thyroid, which can be seen with inflammation or multinodular goiter, and there is uptake in the nasal mucosa, which is also seen here on the cross-sectional images, and this was correlated with symptoms of rhinitis in this patient. So inflammatory uptake of dotatate in the nasal mucosa, and you can see the intensity is mild, and the uptake is not focal to suggest any tumor. This is our next patient with prior history of trauma, and on this axial image we find that there is subcutaneous fat stranding in the linear fashion along the anterior abdominal wall, also seen right here on the coronal image. So this is a characteristic seatbelt sign. When there is seatbelt sign present in a trauma patient, look at the images more carefully for any evidence of trauma. And so in this patient we found a right posterior acetabular fracture. This is our next patient. Here we have a congenital abnormality of the pancreas. So we'll start with the T1 fat saturated axial image right here. Normally there is high signal intensity of the pancreas, and we find that this normal high signal intensity goes all the way around the duodenum. And so this is the pancreatic duct that is more anteriorly opening, superior to the opening of the CBD, and this is more posteriorly that we see the CBD. So there is a divergence between the pancreatic duct and the CBD as they go to the duodenum, and that's called pancreas divisum. Also on the post-contrast image we find that the pancreatic parenchyma enhancing all around the loop of Bowel, which is the second portion of the duodenum, and so this patient has annular pancreas with pancreas divisum. This is our next patient. They were hyperthyroid before performed a ultrasound of the thyroid. Always look at the measurements and the volume. So look at the volume of the right lobe of the thyroid, pretty high. Volume of the left lobe of the thyroid. So it's a pretty enlarged thyroid. We can see that the echogenicity is heterogeneous. We see that the blood flow or the color Doppler images show hyperemia. And so these things are pointing towards Graves' disease. The thyroid is enlarged, heterogeneous, and hyperemic. And the pathology involves both lobes of the thyroid. So this patient was diagnosed with Graves' disease. They underwent a I-123 sodium iodide uptake and scan. So we see uniform uptake in both lobes of the thyroid. Also with Graves' disease, we see pyramidal lobe uptake that we see here. The 24-hour uptake value is elevated at 68%. Normal is 10 to 30%. So these findings correspond to Graves' disease, and the patient should be treated with I-131. Here is a finding seen incidentally on a coronal image from CT of the abdomen and pelvis. That's the fundus of the uterus. Here's the urinary bladder, and we're talking about this linear hyperdensity abutting the uterus. These are Essure devices which are placed in the fallopian tubes for the purposes of contraception. And so when you see them, describe them in the report, and no further investigation is needed. Thank you for watching.